Okay, so the research I'm doing right now, and we'll be doing for the next few years, is focusing at its core on the shifting dynamic in healthcare right now between transactional ties, transactional exchange, and relational exchange. So what do I mean by that? So quick definitions. And this comes out of the management literature and the marketing literature specifically. Transactional exchanges between buyers and sellers are characterized by a distinct beginning, short duration exchange, sharp ending. The obligations between the two parties tend to be standardized, so they're explicit. There's no uncertainty involved in the expectations. Minimal personal relationships are involved. Communication occurs in a ritual-like manner that's often pre-specified. There's a complete transferability of rights. So in a buyer-seller transactional exchange, it doesn't matter really who the sellers are. They may represent one organization or one group, but they can be interchanged, and it does not affect the obligations or the expectations of the buyer. There's not a lot of joint efforts or mutual cooperation in a transactional exchange type system. The primary focus between buyer and seller in a more transactional type exchange is actually on the substance of the exchange. There's no future expectation of either interaction or further exchange. So everything is focused on the actual point in time transaction. And there's a sharp division of benefits and burdens that are allocated to the buyer and the seller. So each side knows its obligations in the transactions. So that's transactional. That compares with a more relational environment, which for decades U.S. healthcare has been characterized, a relational exchange relationship where the commencement of the relationship is traced to prior understandings and agreements. So a doctor and patient come together. They sort of each have an understanding of how a doctor and patient should interact and should relate to each other based on prior exchanges with other doctors, with other patients. The exchange itself is longer in duration. It reflects an ongoing process, so each buyer-seller event is not discrete. It's part of an overall continuum that's constantly reevaluated, reassessed. Obligations are customized, okay, detailed and administered within the relation. So the buyer-seller, the interactions between buyer and seller tend to be tailored to the particular buyer-seller relationship as opposed to standardized across buyer-sellers in the same way. There's important personal non-economic satisfactions that derive from the relational exchange that do not occur in the transactional exchange. So each party gets something more than just the explicit expectations of the transaction. There's more intrinsic, there's more non-tangible rewards that go to each. There's significant focus on the process of the exchange. So the actual relational process is important. It's cultivated, it's nurtured, and it's likely the relational exchange situation includes some sharing of benefits. So there's accountability on both sides. That accountability changes over time. Each party has benefits and burdens that they negotiate with each other, okay, and that are open to some modification over time. So in healthcare, you can think of, transactional exchanges now in healthcare. Where can you really see them? You can see them if you go to a minute clinic. You go to a retail clinic, you go get those are point in time, interactions. They're sharp, they're discrete. You won't necessarily go back to that same provider again. You may not go back to that same store again to get that healthcare delivered to you. If you go to an emergency department, an emergency department is really characterized by a transactional sort of exchange. It has those characteristics I just talked about. Or an urgent care center. A more relational exchange relationship in healthcare might be your child's relationship with a pediatrician over time, okay? Or your relationship with a primary care physician over the course of a few years. So I wanted to sort of give you those definitions because in healthcare right now we're facing this tension, this real juxtapositioning of the need to push more transactions through the system, the need to promote transactional exchange, and the concern is at the expense potentially of relational exchange. So what's driving the need to embrace transactional exchange more in healthcare? Really, it comes down to capacity. Increased access and demand realities, more people getting health insurance, people getting older, workforce shortages, there's not enough providers. So innovation is really focusing on efficiency. Innovation is also focusing on pushing more volume through the system. How is more volume through the system being pushed? Through standardization, through things like aggregating patients into populations. Okay, so the patient is less an individual maybe in a transactional system, more part of a demographic, a diabetic, a hypertensive, an obese person. And technology-assisted interactions and communications are put into the system to reduce the need for more time interacting face-to-face or through extended communications. Relational exchange currently is increasingly not fiscally rewarded, whereas transactional exchanges are fiscally rewarded. Efficiency now, under our value-based purchasing system in healthcare, efficiency is what is being financially rewarded. Time with the patient, extended interactions, those are things that are not being rewarded. So that's what's driving it. And then there's a larger societal de-emphasis, I think, on relationship quality. What do I mean by that? Whole industries are thinking in this way in terms of moving more towards a transactional relationship with the customer, with their clients. Some of this is based on the need in those industries, education, healthcare, retail. Some of it is conscious choice, though, that's rooted in this new definition of value that industries are creating. What's that definition? That definition is that fast, convenient, immediate, and low-intensity service is of value to the customer. Okay? We believe that our customers want this. This also allows organizations to do more with less. So there's a mutual logic, one that's justified for the consumer, one that's justified for the organization. So my research program is really addressing how does transactional thinking and behavior affect provider-patient relationships. That's really what I'm concerned about right now in my research. These are the studies that, two of them, one completed, one ongoing, and one being planned. So I've studied primary care physicians and sort of how their workday is evolving. I've studied primary care practice transformation under the aegis of medical homes implementation, particularly for older adult patients. And then I'm planning a study of how the provider-patient relationship is actually changing. So what have I found so far? What I found so far in the studies I've done, first is that, not unexpectedly to me or others who might be studying healthcare, transactional thinking and behavior is everywhere in healthcare now. It's intensifying in its focus. And it's intensifying because the system rewards are moving it in that direction. So in any walk of care, hospital care, urgent care, primary care, public health, you see an increasing move away from relational thinking, away from relational exchange, towards transactional exchange. These new work atmospheres, I certainly have some evidence that you can say that these new work atmospheres that are highly focused on transactional over relational exchanges have the potential to, in healthcare at least, do what I call dehumanize the patient. So Jim, who's a diabetic, doesn't become Jim anymore, Jim becomes the diabetic. And every time Jim comes in, everybody looks at Jim as the diabetic. And Mary, who comes in, is the next diabetic who comes in. It's not Mary, it's the second diabetic we see today. That's sort of what I'm getting at, this aggregation of unique individuals into, these more obtuse clusters of groups. Relationship quality, what I'm finding is that relationship quality between, for example, doctor-patient, is starting to transform through a focus on what I'm calling faux relationships. What are faux relationships? Those are the way I'm defining them is those are doctor-patient or practice-patient relationships that on the surface look much deeper and intimate and trusting and stable and mutually interdependent, all the things that characterize relational exchange. They look like all those things, but when you look inside them, they're really not. That's just sort of the veneer, okay? And what I'm finding is that valuable information about individuals and their circumstances are being lost because of the emphasis on interacting with patients in a more transactional manner. Key information about them as unique individuals is becoming lost through the exchange. And the question is, how important is that information to good health care? How is that important to good health outcomes? And how do we recapture that information in the system? And then I'm also finding that the providers, for example, in the two studies I've completed, the physicians and the providers themselves feel that the key to success in their patient care is actually on the relational side. So while they're exhibiting more transactional thinking and more transactional interactions, they actually feel like it's potentially making them provide worse care because it's moving them away from the things, the dynamics they feel they need with patients on the relational end: trust, empathy, long-term connections, commitments, mutual understanding, mutual interdependence, all those things that they feel are critical to having the patient comply, having the patient, focus on what the doctor is saying, having the patient be able to interact with the practice and ask questions and feel empowered. So all those things they feel are somewhat de-emphasized in the transactional realm, and while they're able to see more patients, produce more volume on an everyday basis, there's a feeling that the quality, the substance of those transactions is much less than it was before. So to conclude, I think this work is going to help add to the conceptual literature and management, certainly advancing the literature on relational dynamics in organizations, but it also has a very important applied focus. I'm going to try and use the information to assist healthcare organizations in how do we structure ourselves, culture ourselves, and innovate in ways that actually don't tip too far to either towards the relational or transactional end, but try and strike a balance. Because there's no doubt that there needs to be transactional emphasis in order to stay in business. There needs to be volume turnover, but without the relational component, the question will be what kind of care is actually delivered to that setting, and is it high quality care? So thanks very much.